everyone. I'm Dr. Snigdha Chitnis. I'm a maxillofacial surgeon and a category manager here at Midvarsity. I'm in conversation with Dr. Sai Praveen Harnath, a very eminent critical care specialist. And today we are going to talk about sepsis. So as a maxillofacial surgeon, in my own clinic, I'd like to tell you about a case. We had a patient who came in with an odontogenic space infection, Ludwig's angina, which after drainage, he went into septic shock and had to be admitted into the ICU. So I think sepsis is a concept which is important to all areas of medicine. So should we start talking about the basic clinical features that a patient will present when he goes into septic shock?
Great. Thanks, Dr. Snigdha. So I do pulmonology and critical care at Apollo Hospitals in Hyderabad, and one of the things we have realized is that sepsis management can be very satisfying if you can actually jump in early. And as you said, Ludwig's angina, some of our viewers probably know this, but you get this airway swelling, and the swelling can get thick very fast and obstruct the airway. So this is a situation where you need to really look at both the infection quickly and also the airway management quickly. And I'm sure you've been called in the middle of the night sometimes to go and do an emergent tracheostomy, for example, for these patients. And sepsis really is mostly bacterial, and the bacteria gets into your system, and then your body triggers a wave to fight it, and you get all the signs of sepsis: the fever, the fast heartbeat. You might end up with low oxygen. You may end up with a low blood pressure. As your body is trying to fight it, you're releasing all these chemicals which dilate your blood vessels and drop your blood pressure. Now, what we have realized in the last, not very long actually, maybe a decade, 15 years, that early intervention in sepsis makes a huge difference, especially if you can get them IV fluids very quickly, hydrate them back up. If you can actually give them antibiotics very early, in fact, less than an hour, you've shown that you can improve the mortality if you do that. And as you've probably heard from some of the lectures which we've been hearing, the management of sepsis is fairly standardized now. The biggest thing is identify the source. But before you identify the source of sepsis, you may have to start treating. So this is where critical care sometimes plays a role, where you do the therapy before the diagnosis. So for example, in your clinic, when that patient showed up, all he said was, I have a swelling and a fever and pain. And because of your great training, you identified, looked in their throat and said, hey, you know what, this is Ludwig's angina. It's a medical surgical emergency. You need to go to the hospital. I'm going to start antibiotics, and I'm going to alert the team that you need an emergency tracheostomy. So this kind of knowledge comes from, I always like to say, what the mind does not know, the eye does not see. So if you knew this information, that you have a patient presenting with a fever, it's not just any fever. He has a sore throat, it's not just any sore throat. This is an extreme example where you have to act quickly, and knowledge is power, right?
Correct. So since we are talking about the presentations and the clinical features, I just find sepsis to be very confusing to most clinicians because of the varied clinical features that it presents with. So while it can also present with tachycardia, in the later stages it does present in bradycardia, with bradycardia also. So I'd like to ask you how to identify whether a patient is in septic shock in the early stages.
Sure.
To identify whether the tachycardia is due to sepsis or due to something else.
Sure. So we're in 2021 now, and technology has evolved so much. I'm sure there are automated early warning indicators. There are artificial intelligence systems. If you're in a hospital, for example, it'll pick up your change in vital signs quickly and point to you saying that, this patient is prone to sepsis. In many countries, sepsis is a huge burden on the entire financial system, because each person with sepsis has about a 30-40% chance of dying, and if you don't intervene quickly. So in that situation, early picking up of vital signs, as you said, is extremely important. It's not very complicated. Fast heartbeats, low blood pressure are number one. High temperature, of course. There are situations where a low temperature in an older person can indicate sepsis. You can, as you said, sometimes end up with abnormal vital signs which don't match. You could have actually slow heart rates. And this can be complicated in older patients. Suppose somebody is on a beta blocker and they may not be mounting a response of tachycardia. So these can also happen. So when you're managing sepsis, you want to look at the diagnosis as to, is this sepsis or not? Because many other conditions can look like sepsis. Say somebody is dehydrated, volume depletion, low blood pressure, fast heartbeat. So that can happen. As you know, with the general stroke volume equation, if you don't have enough blood flow and blood filled in the left ventricle, your heart might start beating faster. So you have to kind of look at a global picture, examine the patient, always examine the patient, and as you did rightly, looked in the throat, and then what happened to that patient, by the way?
We did go for a drainage. So we started with empirical antibiotics. We then went for a drainage, after which actually unfortunately the drainage was not enough, and the next day we had to go for a tracheostomy, emergency tracheostomy,
Okay.
to save the patient. But then we took a swab. We sent it for laboratory investigation, and when the lab reports came, we could then give a specific antibiotic,
Great.
and it did turn out well. So
Great. So perfect. So what you've really described is when you have somebody where you're suspecting sepsis, you want to identify that this is sepsis. You've done that by the vital signs and the history. You've initiated therapy very early on with antibiotics. You've supported the airway and made sure that he doesn't end up with an obstructed airway, which can happen. And then you urgently intervened and drained the pus, which is control the source in sepsis. And then you kind of kept a watch on how he does, and then he needed a tracheostomy. So what we've really shown in this brief chat about this one particular patient is the entire gamut of critical care. But critical care really involves managing the emergent situation, evaluating the patient to make sure there's no complications, and then doing the next step, which is what happens after the acute illness is over. So now his infections controlled, you actually narrowed the antibiotics, which is very important. And like we were chatting before, antibiotic resistance is a big problem, because the more that people are using antibiotics for non-urgent conditions or for patients who actually don't need antibiotics, you end up in a situation where you have resistant bugs. Now we just get into the COVID pandemic, and there's been so many people have been on antibiotics for a viral infection, which was not required.
Exactly.
And when you do cultures, you end up with these very expensive antibiotics are the only ones that the bug is sensitive to. So luckily in your situation, sounds like you're able to narrow it down, and it was hopefully a good outcome. So a simple thing like a sore throat can be Ludwig's angina, but of course not everything that's a sore throat is Ludwig's angina, but it's important to know this. And it's only because of your extensive training and experience and talking to seniors and reading in books and I guess watching courses, you figured out that, okay, this could be Ludwig's angina. So thanks, Dr. Signa. That was a very interesting case, and we should perhaps talk about the airway management sometime about this patient.
Absolutely.
Great.
Yes,
Thank
that
you.
sounds good.